It's a pleasure to be here this morning. Dr. Chidiat asked me to come and give a presentation about seizures and epilepsy, which is a pretty broad topic. So I tried to put together a presentation based somewhat on what I go over with parents when I meet people in the office and talk about epilepsy, and also some of the topics and issues that parents seem interested in learning about. So first of all, what is a seizure? And a seizure is a burst of abnormal, excessive electrical activity from the brain. So our brain constantly has little electrical currents running through it, and that's what allows us to do everything that we can do. But if a bunch of nerve cells get together and create too much electrical activity, it makes the brain irritable, and then that's what causes a seizure. So a seizure can mean epilepsy, but seizures can also be caused by a few different things. So one of them is fever. That typically is only in younger children. We usually say up to the age of 6 we'll accept that. But if they get a fever because they have a flu or a cold or an ear infection, it can trigger them to have a seizure. Another example would be inadequate oxygen supply getting to the brain. And a good example of that would be if somebody faints, and especially if they don't get down to the ground quickly enough, they can have a seizure because their brain is getting irritable without that oxygen and blood supply. Another example is low blood sugar. So when people, for instance, with diabetes, if they have a drop in their blood sugar, it can cause them to have a seizure, and it doesn't mean they've also developed epilepsy. And then the other one is immediately following a head injury. And people may have experienced that. They've got a small kid who's running and they fall and have just a little bump to the head, but they can have what appears to be a seizure afterward. And again, it's just a sign that the brain got a little irritable with that bump and didn't like it and had a seizure, but it does not mean epilepsy. So just having seizures doesn't mean that we say that you've got epilepsy. So then what is epilepsy? Epilepsy means that you have recurrent, unprovoked seizures. So none of those other things have happened to you. There's no fever, there's no low blood sugar. And we would diagnose a person as having epilepsy after they've had 2 or more of these unprovoked seizures. Epilepsy can start at any age of life, so anywhere from infancy to old age, people may develop epilepsy. 1% of the population has epilepsy, which in medical terms means it's a relatively common condition. Some people will outgrow their epilepsy, and other people do not. So when we think about seizures, we divide them up into 2 big main categories, and that's either generalized seizures or partial seizures. The generalized seizures means that the seizure starts from deep in the brain and spreads to the whole brain all at once. Then in the partial seizures, it means the seizure starts in just one part of the brain. It can either stay just in that part of the brain, or it can spread to involve other areas of the brain. So just looking at those in a little bit more detail. So there's different types of these generalized seizures. The one that probably people are familiar with just from reading, maybe from media, are the generalized tonic-clonic seizures. These are the ones that the parents say are the scary kind of seizures. I thought my child was going to die kind of seizures. And the patient will experience a sudden onset, very, very abrupt onset of stiffening of the limbs, followed by rhythmic jerking of the limbs, plus a loss of consciousness. These can last anywhere from seconds to minutes, even in very severe cases, even longer than into the minutes, into the hours. Patients can have a blue tinge to their lips during these types of seizures. That is your body's way of responding to stress. Your body will know to take life from the less important places and send it to the more important body organs inside. So the lips may look a little blue, fingertips may look a little bit blue. That does not mean the person's not breathing. They're still breathing during these big seizures. So you don't have to panic if you see somebody having a little bit of blue tinge to the lips and to the fingers. There can be excessive drooling or the frothing at the mouth that people talk about, and incontinence. Another common type of the generalized seizures are the absence. This is what people used to call petit mal, but we try to avoid that term these days because it's not really very specific. But these are very brief episodes of loss of consciousness, usually lasting less than 5 seconds. So 2-3 seconds where the child just almost turns off. There can be a little eyelid flickering or a slight loss of the body tone where they might slump a little bit or have a little head nod. And these can happen up to hundreds of times a day. So on and off throughout the day, the child is having them. Very brief little breaks, lapses in their level of consciousness. Another type is myoclonic seizures, and these are brief electric shock-like seizures that go through either just a limb or the whole body. If it's just in the limb, you may see an arm fly out or a leg kick. If it's the whole body, it can have, cause the person to have what we call a drop attack, where they fall right down onto the floor. But it's very brief. They drop, and then they're right back to normal, and they can get up and continue what they were doing. And then the final type is atonic seizures. And this is a sudden loss of body tone in the whole body. But in these ones, the child goes unconscious, so they fall to the ground and they're limp and they're just unconscious for a period of time. These typically don't happen in children unless they already have other types of seizures occurring. So these are not seizures that you usually see in isolation. So if these ones start occurring, it's typically in kids who have maybe some of the other kinds, like the absence or the myoclonic already. And then the partial seizures, which are the ones that come from just one part of the brain, we divide those into simple partial and complex partial. Simple partial means that the seizure starts in one part of the brain and doesn't go anywhere else. So what you see or what the patient experiences with the seizure depends on where the seizure is starting. So if their seizure is in the part of the brain that controls your right hand movement, they may be completely able to talk to you, do their normal things, but they'll have a seizure involving the right hand. So there's no change at all in their level of consciousness. Complex partial seizures means that the seizure starts in one part of the brain, but then it begins to spread to involve different parts of the brain. These are the seizures where patients may experience what we call the aura, or a warning. In fact, the aura is actually where the seizure is starting, so it sometimes gives us a hint as to where the seizure is coming from. So if they can express that they tasted something funny or they smelled something funny, well, that will tell us that that's the part of the brain, the smell part of the brain that it's coming from. If they had flashing lights or saw funny colors before the seizure started, then that will tell us it's coming more from the visual part of the brain. But then because the seizure spreads, it does cause the patient to have decreased level of consciousness. They may not be fully unconscious. It doesn't mean they have to fall down on the ground. Sometimes patients will still be able to wander, or parents will say, it was like he could hear me. He could squeeze my hand when I said to do it, but he couldn't talk back. So there's an altered level of consciousness, but not necessarily full unconsciousness. The patient may also have some unusual gulping sort of noises, lip smacking, and some funny fumbling hand-type movements, and that's also a clue that it may be a complex partial seizure that they're experiencing. Now, I know even as a neurologist who's been doing this for 20 years, seizures are very scary for people to experience, especially the big ones, especially when it's your first or second time around. But there are things that you can do. I borrowed this slide from the Google Images, so it's a little blurry, but I thought it kind of covered everything pretty nicely. So keep calm. Try to not panic if it starts to happen to your child. You want to let them have lots of room. Don't let people crowd in around them. And then protect them from injury. So if they're near a table or a chair, move any piece of furniture so that they can't injure themselves on it. If the child or adult has anything tight around their neck, you can try to loosen it if you can do that easily, and put something soft under their head, like a towel or a cushion. Most importantly, you want to roll the person onto their side so that if anything is coming up into their mouth, be that the salivation, sometimes people vomit a little bit during a seizure, so if anything comes up into the mouth, you want it to be able to come out onto the floor. We don't want people to be lying on their backs and then choking on anything that's in their mouth. Along with that, never put anything in their mouths. You cannot swallow your tongue. It's a total old wives' tale. It's firmly attached to the base of your mouth. It can't go back and block breathing. And as I said before, people do breathe during seizures. It's sometimes hard to pick it up, and it can kind of be a more shallow type of respiration, but they are breathing. So never put anything into their mouths. If you try to put your fingers in, you'll get your fingers badly bitten. And if you put anything else in, they may bite it off and choke on that object. So keep the mouth clear of anything that's superficial that you can wipe off, but don't put anything in. And never restrain them, because you may get hurt, or it may hurt them if they're trying to fight against somebody holding them down. Seizures seem like they last forever. It's almost impossible to judge time, but we'll usually say to parents, especially if it's not the first time, but if it's happening to them over many periods of time, to try to time the seizure so that they have an idea of how long it's lasting. If the seizure stops in less than 5 minutes, you don't need to take the child emergently to hospital. You can allow them to just rest and recover, and then they may need to be seen later after they've recovered. But if the seizure lasts 5 minutes or longer, that is more of a medical emergency, and then we would say that you should call 911 at that point. Now, lots of my patients will say, we don't wait, we just call 911, that's fine too. But medically, we will say you can allow the child to, the seizure to continue for up to 5 minutes, and if it stops at 2 or 3 or 4 minute mark, and they're just tired, then you can just allow them to rest, and that's fine.
Excuse me?
Yes.
A question to do with that. I know like a single seizure lasting over 5 minutes. Now, a lot of our kids have cluster seizures with very short periods in between. Is there any kind of protocol?
So as long as they come back to pretty normal in between each seizure, then that's okay. Again, you don't need to do anything emergently.
Okay.
If they had a seizure and it was like 2 minutes and then they were still deep unconscious and another one happened and they were still deep unconscious and another one happened, then it's probably a good idea to get them to a hospital quickly. But if they had a seizure and then they kind of recovered and half an hour later they had another seizure and then they recovered, then that is not considered a medical emergency. Now, if you do end up going to the emergency department, the kids actually don't need very many investigations emergently. There's not much that they're going to do as long as the seizure has stopped. If the seizure is going on past 5 minutes and the paramedics come, then sometimes checking the blood glucose or blood sugar level can be helpful to make sure that they haven't had a drop in their blood sugar. But other than that, there's not really any other blood work investigations that the children need to have done. The two more important tests are the ones that we do typically as an outpatient, and these are the EEG and the MRI test. So an EEG is a test that measures your brain's electrical activity. The potential for a brain to have seizures shows up as what we call a spike on the EEG. When we do this test, it can help us to say where the seizure came from in the brain. It can help us sometimes to choose appropriate medications because different seizure patterns or seizure types will respond better or worse to certain medications. EEG does not hurt. There's no needles. Back in the old days, they used to do them with needles and stick them into people's skulls. That does not happen anymore. It's now done totally just with little metallic discs that are just laid on the child's skull with a little bit of paste. So there's no needles to it. It's not a painful test. There's no radiation. And sometimes some children will need to be a little lightly sedated because to get a good recording, we need the child to be able to lie a little still and not pull at them and not cry because of it. So sometimes we will give the children a light oral sedation just to keep them a little happy during it. So this is what we might find. The picture on the left, I don't know, is there a laser pointer or any typer? Oh, okay.
Over your light, you're just connected to your laptop.
Tech support? I just wanted to feel this. You're gonna have to pay him extra. Okay, so so this is an EEG, and all these little tiny little whoops bumps are what we would normally see. These are all normal waves. And then these ones, that as an old instructor of mine used to say, looks like the spike looks like something that would hurt if you sat on it, with the big waves afterward, is what we look for seizures. And in this patient, what they're trying to indicate is that, lost my pointer again, that because it's only in some of the channels, this would be what we would find in a partial seizure. As opposed to on this side, where it's happening in all of the channels at the same time, this is what we see in a generalized seizure. And the other test is an MRI scan. MRI uses magnetic waves to take very detailed pictures of the brain. It's much better than a CAT scan, and really we say we want to try to avoid CAT scan in children because of the risk of radiation to developing brains. So MRI is the much better picture. What we're looking for is small areas of the brain that are perhaps formed in slightly unusual ways or in disorganized ways, because that can help us to, again, localize where the seizures are coming from. Again, it's not a painful test, but it is the test where you've got to go into the tunnel and lie totally still for up to an hour. So most children will need sedation to get through the MRI. Even lots of adults will need sedation to get through an MRI. So that's not unusual to expect that. So just a picture. An MRI machine, you lie on the bed, you go in the big tunnel that looks like a donut. I've got a couple of pictures here to see if I can get my mouse to respond. Oh, there it goes. Okay. So this, where the big arrow is, you can see is when you look at the whole, on the other side, this part here looks pretty much the same as the whole rest of the outside of the brain. Nice light gray color. Over here, on this side, you've got this big white blob that's not really as well organized. That would indicate a little abnormality in that brain, that area, that part of the brain, and that may be where the seizures are coming from. Another one on the left side here, we have a normal brain. There's this nice ribbon of light gray cortex on the outside of the brain. On this person's brain, they mostly have that ribbon of cortex, but here we've lost that. There's a bit of almost like a cyst, and that again would be an indication that that's where that person may be getting their seizures from. So how do we treat seizures? First of all, I want to talk about rescue medications, or medications that may be used emergently. The two main ones that you'll hear about are Ativan, which is lorazepam, or Valium, which is diazepam. I don't know if there's any Americans here today. Valium is the one typically used in the United States, I think, more often. Ativan is given in Canada. These medications are used in a patient if they have a seizure that lasts longer than 3 to 5 minutes. Different neurologists will give different instructions. I tend to say at 3 minutes you give it, but everybody would agree that certainly by 5 minutes you would be giving this medication. Now obviously if it's your child's first seizure, you won't have that at home, but this is what paramedics carry as well, so that if they're called to a child who's having a seizure that's not stopping, this is what they would administer. The Ativan medication is typically given as a pill that goes just inside the wet side of the cheek, and it dissolves and goes into the bloodstream to stop the seizure. The Valium is typically given rectally. Lots of people know these medications because they're used in other conditions like anxiety and panic disorders and things like that. And in adults, they do tend to calm us down and make us sleepy. But in kids, they can have what we call a paradoxical reaction. Where they can get quite hyper, which can last up to about 24 hours and can be quite sort of alarming for the parents, because often they'll feel like, oh my goodness, something's gone wrong because of the seizure. Although it can be a real trial to get through that period of time, we would still encourage, if you have to use this medication, you should use it, because it's a worse thing to have the seizure go on for longer than 5 minutes. So getting it stopped is important. So what about you taking a daily medication for seizures? Most neurologists will recommend that a child start on an anti-seizure medication, or an AED, if they've had 2 or more seizures. Once you've had 2 seizures, the chances of having a third is about 80%. So a lot higher risk that a third is going to happen than not. We also can never predict when that could be. Could be tomorrow, could be in 6 months. These are unpredictable things. So once a child has had 2 of these unprovoked seizures, we'll typically start having a discussion with families about starting on an anti-seizure medication. The choice that you pick will depend on the type of seizure that the child is having, the age of the child. Certain anti-seizure medications are not good in very young babies. And if they have any other health conditions that we have to consider, or other medications that they're taking, we've got to take that into consideration. Why do we encourage you using a daily seizure medication. The first reason is pretty simple. Patient safety, obviously, is really important. If you have a seizure at the top of the stairs or on the slide in the playground, you can get hurt and injured. So we want to try to prevent falls, injuries, anything else sort of safety related. So that's pretty simple to think about. There is the possibility in certain children that by treating their seizures, you may enhance their development and their cognitive skills. You can imagine if you have the type of seizures that happen up to 50 or 70 times a day, even if every single one is very short, over time that each little blip of time can add up, and all those times are potential learning time lost. So depending on seizure types and seizure frequency, sometimes improving the child's seizure control can impact their learning. It's not a guarantee, but it's certainly something that we have to consider. Another issue is one that's still being researched and nobody is really certain about, but there is scientific evidence that suggests that allowing the brain to continue to have seizures is like the brain practicing having seizures. So just like you practice your piano scales to get better and better and better at those, if a brain is allowed to keep having seizure after seizure after seizure, it's possible that the brain gets better and better and better at having those seizures. So that over time you may be less likely to grow out of them, or the seizures may become more resistant to treatment. That's not something that's been definitively proven, and people are still looking at that at the level of more animal models, but we always sort of want to keep it in mind. And then another big reason is something called status epilepticus. Status epilepticus is when a seizure lasts longer than 15 minutes. Status epilepticus can occur with any of the types of seizures that I mentioned, but the commonest is the generalized tonic-clonic seizure. And you can imagine that if your body is in this rigid, jerking movement for 15 or 20 or 25 minutes, it's extremely metabolically demanding on both the body and the brain. And so it can result in permanent brain damage and even death to the child for the patient. So it is treated emergently. And most neurologists would feel that if a child has had one episode of status epilepticus, we would really try to encourage the family to start thinking about using a seizure medication if they aren't already, to try to prevent that from happening to that child again. So I'm just going to run through a few of the common seizure medications. This list is not exclusive, but some of these ones are the ones that you might be familiar with already or have read about. So one commonly used seizure medication is Tegretol. Its generic name is carbamazepine. It's often a first choice in children. It tastes very good. It comes as either a very tasty liquid or a very tasty chewable, which all of you with small children will know is very crucial when you have to take medicine 2 to 3 times a day. Side effects sometimes at the very start of using the medication. Sometimes there can be a little bit of drowsiness, but that does typically resolve within 2 to 3 weeks. You can be allergic to Tegretol, and of course we can't know that until the person starts taking it. It's not an allergy like a peanut allergy where the first dose would make them go into not able to breathe. But if they started to get hives or a rash, then we would say, well, we have to stop that medication. There is the potential to have a lowering of the blood cell count, so the white cells which fight infection, and the platelets which do clotting in our bloodstream. But it's pretty rare. I've only had 1 or 2 children over the years have that. And then liver dysfunction, which is even more rare. But it does mean that the child will have to have a blood test done occasionally to keep an eye on those parameters. So sometimes that has to factor into our decision making, how difficult that's going to be for the child. Another common one is valproic acid, which has got other names, Depakine, Epival, you might know it as one of these names. Another frequent first choice. It comes as either a pretty tasty suspension or as a capsule for kids who can swallow pills. Some of the commonest side effect I think that parents report to me is that it really causes increased appetite and sometimes some fairly significant weight gain. So that is something to be aware of. Yep.
Now, to do with valproic acid, the carnitine issue. Now, I mean, obviously, the syndrome is very, very new, and we don't know if all the kids will have similar metabolic reactions or whatever. But I know that it's also one of the first choice drugs. But I know that, like, just just generally with Mike, he did have the carnitine reaction. and
Okay,
it was
yeah.
pretty severe.
Was it? Yeah. I didn't think to include that on here. So carnitine is a vitamin basically that our muscles need to sort of be strong and function well. And if you don't have enough of it in your body, you can feel sort of tired and weak and very fatigued. We get it from eating meat, and most of us, if we eat a fairly average diet, similar to a diet to prevent anemia, you'll have enough carnitine. But if you're taking valproic acid, you basically urinate it out too much. And that can happen even in children without any chromosomal abnormalities. So it is, if parents say to me their child feels more tired on this medication, then I will usually check their carnitine levels, and check it maybe every 6 months just to keep an eye on it. It is replaceable if the levels get low. You just take it as an oral supplement. Did your son have to stop taking that?
His total and 3 were 0 and 1.
Oh my word.
Yeah,
Yeah.
so
Thanks.
he was followed actually here at Sickkids by Dr. Tyne. And so he went on Carnitor for
Yeah.
a number of years.
Mhm.
He's off it now, and we've tested and it seems okay, but I mean, he immediately went off the valproic acid.
Right, because that's a pretty extreme response.
Yeah, but I
Most
didn't
kids will
know
drop a
if-
little bit, but not to that extent.
We didn't have a
yeah.
diagnosis
Yeah.
at the time, so I didn't know if it's something that, people in the room should be aware of as well,
Mhm.
just in case there is some kind of metabolic.
Yes,
connected
some
with it.
link, yeah, which is interesting.
Yeah.
Yeah. And I did read online that it is often a first choice in the nicolaides baraitser syndrome, probably because it's an anti-seizure medication that covers a lot of different seizure types, which some of them don't, but that may be something that's good to keep in mind. Yeah. Another common one that's, it seems to me that Sickkids Emerge is loving this medication lately, Keppra, levetiracetam. It's a pretty good first choice for medications. However, its most common side effect, if you're going to get a side effect, it's typically hyperactivity and extreme behavioral problems. And unfortunately, that tends to happen more often in children who already have developmental delays or developmental disabilities. So it's not necessarily one that I typically will lead to as a first choice, but it is available. It's nice in that there are no other organ or body effects, so there's no blood work to be done. And it comes as a crushable tablet, so it is pretty easy to administer even to small children. Another one is lamictal or lamotrigine. This one, if you read about seizure medicines, you'll typically see it listed as what we call a second line or an add-on medication for a child who's failing a first or a second choice medication. Not many side effects, except that if you start the dose at too high a dose or increase it too quickly, you can get a really, really serious rash called Stevens-Johnson's syndrome that can actually start to affect your liver and your kidneys and everything. So it can take up to 4 to 6 months to get to a point that you're taking a dose where it is going to possibly help your seizures. So that's not why it's one we don't usually use as a first choice, because you have to be very patient with it. But if you get the child onto it and they tolerate it in terms of the rash, otherwise it doesn't have very many side effects. Comes as a chewable tablet, so again, pretty easy to give and no blood work to do on it. And then the last one I wanted to mention is just topamax or topiramate, also one of these add-on medications. I think it has more side effects than some of the other ones. It almost always causes decreased appetite and weight loss, which of course for some children can be a big issue if they're already small to begin with. In my opinion, it does tend to cause some attention problems and sometimes some cognitive problems, and rarely, more often in adults, but it can cause kidney stones, so the children will need to have blood work done yearly if they're taking it to keep an eye on their kidney function.
Also, I noticed with Mike that he doesn't sweat with it.
Oh, that's interesting.
And he's got, what is it,
Urea.
something to do with the sweat, not the, maybe it's the urea. But he also, when he's on topamax, he dumps oxalates about every 2 weeks. He's got like you can see it. So, I mean, that's, I guess,
Consistent with the kidneys, yeah, so you do have to keep an eye on kidney function. So I have to say it's not one that, it's usually pretty far down my list of ones that I like to use.
Sorry, can I?
Yeah.
Keppra, my son's actor's on.
Yeah.
And you were talking about hyperactivity.
Mhm.
So, to help me understand, is that, that's just a common side effect, or it does actually contribute to hyperactivity?
So I think it probably is a combination of both. So I think if you have a child who perhaps is already has some developmental delays, then their attention span may not be at what their age level should be, right? And so they've already got some attention problems, but then the Kepler just somehow seems to just let it go wild. Yeah, they can become really irritable. Parents will tell me, no, their 3-year-olds are running out into the street, and you know, we'll sometimes have to stop it because it can be such an extreme change.
My son, I find, sorry for these questions, is vocal in the sense from being, I'm making an assumption, is unhappy or, so I'm not sure, is that the medication as well that could be?
It's interesting. Did you notice it after? Like, did that come on after, or it's hard to tell?
It's hard to tell
Yeah.
because he started off on clobazam,
Right.
and then when they moved him off that and put him onto the Keppra, now he's on the Keppra. He hasn't had a seizure for about a year and a half, but yeah, I'm just more trying to relate it to hyper aspect of it. And
And sometimes it's hard to know, you know, and there might be different factors playing into it. Again, developmental level, and not as much ability to express yourself, but wish to express yourself, so you're more frustrated as you grow older. There's probably a lot of different things that add to it. The only thing that perhaps relates is as I said, this side effect doesn't typically happen in children with developmentally typical children, but I did have one teenager who said to me, I have to stop this medication, it's making me feel more like a teenager. So he was just angry about everything and just couldn't control that sort of, you know, irritable feeling inside. So hard to know, yeah. And then of course it's tough if you've got a medication that's working for your seizures, but causing side effects that you don't like. Where's the balance? It can be tricky.
does any seizure medication typically sedate? Does it bring the brain
So, for instance, Tegretol can be a little sedating at the start, but that typically does go away. Phenobarb, which is an older medication we use only usually now in very small babies, can be a bit sedating. Valproic acid doesn't sedate people, but it has what we call a mood stabilizing effect. So it's even used in psychiatry these days to help sort of people sort of just kind of stay even keeled. So that one sometimes is good for kids who, if they already are on sort of that cusp of attention issues. Sometimes valproic acid can be helpful. Sometimes it just evens it out a little bit.
Can I ask a question about the
Yes.
Keppra too? So we're on Keppra therapy too. We're now at our maximum dose of Keppra because of a reoccurrence of seizures after a year and a half.
Oh, yeah.
We utilize the B6 because of the hyperactivity, but we've kind of noticed now that we're at that maximum dose, it's really not as effective as what it was before. Is there anything else that you're aware of that they utilize to kind of counteract that effect of the drug?
Sometimes in children who are old enough, they may have to go on to like the traditional stimulant medications for ADHD, and in some children that can be helpful. But your little guy looks old.
Yeah.
Probably, so he's probably on the inside. Other than that, I don't know. No.
Okay.
Yeah. Okay, so what do we do if medicines don't work, which can certainly be the case? So many of you may have read about or heard about the ketogenic diet. The ketogenic diet is a very high-fat, low-carbohydrate, adequate protein diet. It's based on the idea that our brains use preferentially blood glucose or blood sugar as the energy source. But as all of you know, if your kid drinks a whole bunch of Kool-Aid at a birthday party, they get a little bit hyper. So the idea is that maybe if we force the brain to not use blood glucose and instead switch to using ketones, which is the breakdown product of fat, as the energy source, there seems to be something about these ketones that's really protective against seizures. So So it's a diet where the patients eat a 4-to-1 ratio of pure fat to protein and carbohydrates. You have to completely eliminate the starches like the fruits and the breads and the pastas and the rice, and increase your consumption of high-fat foods like butter, cream, nuts. So here in North America, we love our carbs, our rice and potato and bread and pasta. We eat a little bit of our vegetables and fruit, not very many greens, and adequate protein. The ketogenic diet switches it to a pure 75% fat diet, with still 20% protein and only 5% carbohydrate. And this is a picture, just an example of what people might be eating. So big pats of butter, only a little tiny bit of greens, fish, oils, steak, coconuts. It's not as simple as just going to McDonald's and ordering up a Big Mac and fries for your kid every day. It really is pure fat that they need to be eating. And it has to be calculated gram for gram for the child. Like every single meal is done individually for each child. So it has to be done under the supervision of a dietitian to make sure that the child's nutritional needs are being met. It's probably more effective for children who have generalized seizure types, but it also does sometimes work in partial seizure disorders, so it can be offered to anybody whose seizures are not responding to medication, what we call intractable seizures. Side effects, it's not easy. Every single meal, as I say, has to be worked out, doing math, gram for gram, what they're going to eat. It's quite restrictive. You can imagine your kids can't participate in somebody bringing in a cupcake birthday party at school. They have to take special vitamins that have no sugar. You have to get toothpaste that has no sugar. So it's really quite a lot of work, and it can be quite expensive as well. Because of course in our culture, starches are cheap and things like meat and fish are expensive. If you eliminate all your greens and fruits, constipation can be a common problem. There can be raised levels of blood cholesterol in these children temporarily, but fortunately once they finish the diet, it does not seem to have any long-term effects on their arteries or anything like that. This list is not a full list of side effects of the diet, but these are sort of some of the common things. Surgery might be an option for certain patients who are intractable. It's only possible to do surgery if the patient has a focal onset of their seizures, especially if you can localize a particular area of abnormality on their brain over time. It takes a big workup by an epilepsy surgery team to get the patient to the point that they would be ready and deemed appropriate for surgery. Obviously, you don't want to do surgery in a patient that have them have some sort of new deficit afterward. So it takes a long time to get to the point where you can say a patient is a candidate. And then finally, vagal nerve stimulation. The vagus nerve is a nerve that runs from the brainstem of the brain down through the neck into the chest and abdomen, and it basically works all of our body organs. A vagal nerve stimulator in people with intractable epilepsy can be implanted in the chest and then attached to this nerve and used to give repetitive pulse stimulation at a certain frequency that hopefully will override the seizures in the brain. Unfortunately, it has not turned out to be particularly effective, at least in children. A colleague of mine who does it at Sick Decision, she doesn't really think it works at all, and it's probably been done so just briefly to touch on seizures, specifically in nicolaides baraitser syndrome. It occurs, it seems to me from what I read, that it's about 2/3 of the patients will develop seizures. It can start at any age, so from infancy, toddlerhood, up through childhood, seizures can start occurring. All of the different seizure types have been reported, and each child may also themselves have different seizure types. And unfortunately, the seizures sometimes will be difficult to control fully with medication. So is there anything that you can do as parents to try to prevent your kids from having seizures? So regular meal times is really important. You can imagine if a person who doesn't have a predisposition to have seizures gets a drop of blood sugar and can have a seizure, then somebody who already has a predisposition to have seizures gets a drop of blood sugar. It's really unlikely to happen. So regular meal times, regular snacks, trying to get them to eat something consistent times throughout the day can be helpful. lots of sleep, because fatigue can trigger seizures. Treat fever with acetaminophen, Tylenol every 4 hours, or ibuprofen, which is Advil and Motrin, every 6 hours to try to keep the fever down. And if your child is on a daily anti-epileptic drug, trying to give it at the same time every day can be helpful. It helps the body to expect a kind of regular amount of that medication in a 24-hour period. I have some patients who can miss a dose or be haphazard with their timing and be fine, and I have other patients who, if their parents are off by half an hour, they have a seizure. So just trying to really stick as much as you can. I know that's not always totally possible, but as much as you can, trying to stick to a regular dosage time can be helpful. Something that I want to bring up, it doesn't always get brought up in doctors' appointments, is sudden unexpected death in epilepsy patients, or SUDEP. This occurs in about 1 in 1,000 people with epilepsy. It's defined as the sudden death in an epileptic patient who has no other acute health problems. They don't have a pneumonia, they don't have the flu, nothing else new has started to happen to them, but they suddenly die. And the autopsy shows no other cause of death. It occurs more commonly in patients who have poorly controlled and frequent seizures. Typically, the patients are found dead in bed, lying on their stomach, but they don't necessarily have had evidence of having a seizure just prior to the time of death. Some theories about why is that it may be that they have a seizure, but you can't tell, and that they've suffocated because they're lying face down. But other people postulate that something about the seizures in the brain triggers an abnormal cardiac rhythm, and so that they actually may die from a heart event more than a brain event. Can we prevent it? Unfortunately, at this time, there is no known prevention for SUDEP, but because we know that it happens more often in people whose seizures are not well controlled, aiming for best seizure control possible is important. And so the goal of having people on seizure medications is to try to get them to the point where the seizures are, if not 100% controlled, as best as we possibly can. I typically tell families that if their child has nocturnal seizures, then they should consider having their child sleep without a pillow. Usually I'll say let them fall asleep with their pillow and then just take it away before you go to bed. It's harder to suffocate in a hard mattress than it is with a pillow wrapped around your face. So take away the pillow, take away all the stuffed animals so that they've got their room around them. And consider having a baby monitor in their room and your room so that if any unusual sound is happening, you may be alerted to something happening. Parents will often want to know, well, are there seizure alert devices out there? And there are a few different ones available. I'm sure more and more will come to market. Some of them go under the mattress of the bed and detect vibrations. And some of them are worn as wristbands and alert the parents if the person has repetitive movements. But that will only work if your child has seizures that have these big repetitive movements. So if your child has a seizure where they're just stiff, these devices may not be effective. But these are the ones that are available right now. They also can't pick up changes in the heart rate or the breathing, which again may be important in SUDEP. So we don't know yet if these devices will help in preventing SUDEP. But if your child does have seizure types where they're shaking, it may at least alert you to a seizure happening in their sleep. And there is more information available on these on the Epilepsy Ontario website, and I've got that at the end. So one topic that's coming up a lot lately is epilepsy and marijuana. People are asking about this a lot. And really, all the reports pretty much at this point that people think it's efficacious are anecdotal. There's only one scientific study that was done on humans looking at marijuana as a treatment for epilepsy, and it was done in 1980, and the results were conclusive. So at this point, we really don't know. There are some animal studies that suggest the 9-THC component of the marijuana may be helpful, but some other animal studies that suggest that marijuana might trigger seizures to happen. So I think at this point, the bottom line is that we need a lot more research before we're going to start hearing about marijuana as a regular treatment.
What kind of research is going on now?
I know Sickens was thinking about starting a protocol, but I don't know how far they've gotten.
Now, were they thinking of using the Pedialex or
To
you
be
don't know
honest,
that?
I don't know enough about it, to be honest, yeah.
Unfortunately, it doesn't seem that people are really jumping into the research field
Yeah,
for
I
the
think it's,
marijuana, and so we're all
it's-
sitting back and saying we don't know yet.
yeah, I don't know honestly how much other research is being done, I don't know if they're doing other
So there is a clinic in Denver and another one in
New York is doing.
Israel. There is a one using it, but no real use of it. And they hired actually one of the autistic kids and does the research.
Oh,
Perhaps after maternity leave.
I had read an article, and I wish I could quote who and what, because you know how when you're on the internet, you don't know what you're seeing. But that had said that CBD use could increase the levels of clobazam in the body.
I don't know.
You don't know.
I don't know. I think part of what worries people about marijuana in children is we don't know enough of the potentially other effects on the developing brain. So we know, for instance, just in normal teenagers who smoke it, there's a much higher risk of developing schizophrenia, for instance, than if you start smoking marijuana as an adult. So there's, I think, the added component when looking at it in children, that we don't want to fix their seizures, but then cause some other massive developmental.
But then I thought that was more of the THC that was causing the problem as opposed to the seizure.
I don't think that's enough well known yet.
There's not enough
Yeah,
information.
yeah, because we just don't know enough, you know, that drug in small children.
Concentration
Yeah.
Well, the problem is you can't get it consistent. You can't get it
Right,
consistent.
it has to go to Alberta where they extract it actually and put it in an oil form, and nobody knows the concentration, so I have one patient who one oil extracted became completely drowsy, and then another dosage caused more seizures. Very difficult to do.
So I think we're a ways yet from that one as a regular offering. So just a few other things that I usually will tell parents. People with epilepsy can participate in all activities. Anything they want to do, they can do it. Swimming is fine as long as they are at a pool that has a lifeguard or they're with a responsible parent. Bathing, if you're in a bathtub, it should always be with a parent or responsible adults with them, but showers can be private. It's worth considering having your child wear a medical alert bracelet if they're old enough that they may be a little bit independent from caretakers. So if they're using wheel-trans or if they're able to use public transportation, it's a good idea that they have a medical alert bracelet. Small children who are always with a caregiver don't need it so much. And understand your child's triggers can be really important. So does your child get them more if they're fatigued or ill or excited or stressed out? And those things can help you individually. So just to wrap up, Lil Wayne and his epilepsy. So Lil Wayne is a pretty big rap star. Apparently, I don't know much about him, but Lil Wayne has epilepsy. And I guess a couple of years ago, he got quite sick and was hospitalized. And this is a quote from an interview he did afterward. The bad news is I'm an epileptic. I'm prone to seizures, he told the radio station. Like, this isn't my first, second, third, fourth, fifth, sixth, seventh seizure. I've had a bunch of seizures, y'all just never hear about them. But this time it got real bad because I had 3 of them in a row, and on the third one, my heart rate went down to like 30%. Basically, I could have died, so this is why it was so serious. But the reason being for the seizures is just plain stress, no rest, overworking myself. So I think this summarizes epilepsy pretty well. Epilepsy can occur at anybody. It's recurrent seizures. They can be very serious, but you've got to know your triggers if you can. So just to finish up, there's a few resources here where you can get excellent information about epilepsy. EpilepsyOntario.org is the website that has the information about seizure alert devices. Epilepsy Toronto, I don't know if anybody here has dealt with them, but they're just a wonderful organization. They'll go to schools to do teacher training. They'll write letters for parents if they need them for travel or for kids going to special camps or something like that. About Kids Health is the Sick Kids website. They've got information about lots of different topics, but their epilepsy component is excellent. And then suitablewear.org. So that's it.
Okay.
Everybody wants to listen.
My son had seizures, 16 months of age, so he had 7 seizures in a 1 week. He was brought and admitted to HSC. Seizures were eventually brought under control by 3 different medications for about a year. Pyramid would be one of them. Because children with this syndrome, his birth weight is probably in the 50th percentile. And most children, from what I can gather, are behind to begin with. And because they became an appetite suppressant, they started to wean off. In the process of weaning off, which is something that scares me, his seizures came back. Every 2 weeks over a 13-month period, he would have clusters of seizures. No emergency meds work to stop him. He have to be brought in and be administered an IV phenobarb. So he's on phenobarb, Keprov, and Diamox right now. I had noticed that the PHA level, through a study that I read from Emory University, in people who have seizures is lower than people who do not have seizures. I started giving JV tuna, a couple of tablespoons a day. In the 2-week period in the baby monitor, there was no seizure. 2 weeks turned into a month. It's now been since 06. So he's had no seizures. He's still on the same medications. They have not been increased. So I'm hoping for a natural wean. Phenobarb can be measured in how well the level is doing anything or not, but the other 2 can't. So my question to you is, because of our scare with weaning off and having everything come back and that being so much harder to control again, it's been since 06, do I dare take that plunge again?
That is always a very hard question, and I think it's something that parents always make very individual decisions about. So sorry, I was just saying that's it's a really hard question, and it's very individual to every family, I think. What we typically say medically is that if a child has no seizures for 2 years on their medication, then we do an EEG again, and if the EEG is looking normal, then we can start weaning them off medication. If they're on a couple of medications, then we'll pick the one that the parent likes the least usually and go with that one first and see how things go. But I'll often have families say to me, I can't do it, I can't take the risk, you know? And if they feel that, you know, we're used to these medications, my child tolerates them fine, there's no big issue to continuing to take them. I think you really have to feel yourself that you're ready to try it, yeah. Mm-hmm. But it's hard, I know, yeah.
Isn't there long-term effect on any medication typically though?
Honestly, not really. No. As I said, you know, with the different medicines, sometimes there's different things that we'll monitor over time, but not really. No, you can be on any of them for years and years, and there's not any big reason to have to come off them. Yeah. Sorry, I think that.
Just a question about diet. Is it beneficial to have a diet that's high in omega-3s? Like, has there been any work done on that to sort of support that view?
So the question is about high omega-3.
Yeah.
Not to my knowledge, although there's always so much different things coming out. We usually just say to parents as much as possible, have a balanced eating a balanced diet is the best thing for their children. Certainly giving them supplementary omega-3s or increasing it in their diet is not going to do them any harm, but whether it's proven, not to my knowledge.
So now a lot of with what we call alternative therapy. If you go and get the website for the intellectual disability population, you're gonna find a lot of families claim that and there are certain formulas for every syndrome. I don't know if you guys have one for nicolaides syndrome, but like a lot of syndromes, they have a preparation for an alternative therapy, which include high omega-3 and other components. There's a study we're going to be published soon from Holland Blue Review. They did a big randomized control study looking at omega-3 and autism, and there was no difference. And this study being like, I think, for two years, They basically looked at certain symptoms, including cognitive as well, and there was no difference. And I think the placebo one who did not go to Omega, they showed
Any other questions? So we have lunch. So Risham actually went and brought it here and enjoyed. One possibility is to bring the lunch here so you can have conversation between people here, or there is actually a place there that you can, near the lunch, that you can spread out a little bit and enjoy it. I would like very much to have pictures. So we have stairs just in front of this place, and perhaps we can sit on the stairs, and you are the photographer? Okay, so we'll take before lunch, let's take a picture and go to lunch, okay? Thank you very much. Thank you very much for the speakers, and all the best.